Good morning, everyone. I'm Heba Abdlhamid. I'm one of the Pediatric Cardiology Senior Clinical Fellow at Bristol Children's Hospital. And today I'm going to speak about one of the interesting cases I've seen during my CMR fellowship at the Royal Brompton Hospital, UK. So the title is Unusual Cause of Myocardial Infarction in a 3-year-old and the role of cardiovascular magnetic resonance in the diagnosis. So this is only a very small background about myocardial infarction in young children and how it is exceptionally rare in young children. Most cases are linked to congenital or inflammatory causes, and diagnosing myocardial injury in children is quite challenging because of the overlapping clinical presentations. However, cardiovascular magnetic resonance plays a great role in resolving these diagnostic complexities, which I will show in the case presentation. So we have Lily here. Lily is a 3-year-old presented to her local hospital with symptoms of lethargy and breathlessness. 10 days prior to her acute presentation, she went to her GP for periorbital swelling, who treated her with antibiotics as presumed cellulitis. She's known to have iron deficiency anemia and pica. Family history-wise, she has two siblings with iron deficiency anemia requiring iron transfusions. Her father had a stroke of unknown cause, and she has always been fit and well, no fatigue, no chest pain, or any other illnesses. So on clinical examination, she has persistent tachycardia and systolic murmur, and her chest X-ray showed cardiomegaly, and that's why she was referred for an echo. So she had an echo done, which confirmed the diagnosis of dilated cardiomyopathy, severely reduced LV systolic function. Her LV ejection fraction was around 16% measured by Simpson biplane method. No LV outflow tract obstruction. There was thrombi in her left ventricle, small to moderate pericardial effusion, and her coronary arteries were checked and were clearly seen by echo showing normal origin and proximal course of the right and left coronary arteries. So let me get the pointer. So this is here echo images in a short axis view, 4-chamber view, showing a thrombus in the left ventricle. And again, this is your short axis view echo image and 4-chamber view showing the globally reduced LV systolic function. So initial investigations, her initial blood tests were done. She had a full blood count, which showed a hemoglobin of 77 and MCV of 64, and she had iron profile, which was quite low, confirming iron deficiency anemia. And then she had troponin levels done. So this is here a graph showing her troponin levels during her admission. She was admitted for around a month. The normal reference is between 0 and 11.6. And when you look here on admission, her troponin level was quite high. It was around 200. And in 24 hours, it kept going up to 800, and it peaked at 7 days, 1800 or 1800. And this elevated and progressively rising troponin level indicated an ongoing myocardial injury. She had also an NT-proBNP done, which was very, very high, 17,183. And because of her echo findings of dilated cardiomyopathy, workup for cardiomyopathy was done, including selenium level, carnitine level, which were normal. She had a metabolic screen which was normal, and her lipid profile was within normal ranges. So when you look at this clinical picture of a 3-year-old presenting with rising troponin level, the first thing that comes as a diagnosis comes to your head is myocarditis. And when you look at her ECG here on admission, it was normal sinus rhythm of a heart rate around 130, 140. There was no ST changes. However, 72 hours after her admission, we have repeated the ECG, and you can see here there is ST elevation. I'm sorry if it's not clear, but you can see here ST elevation in lead 2, lead 3, AVF, and in V5 and V6. And these ECG changes prompted further investigation with CMR. So when you have a referral of a 3-year-old with a possible myocarditis, when you protocol it, there are a few sequences that you need to make sure that they are done that will guide you to the diagnosis. First is the stir image, the stir sequence, which is very, very sensitive in detecting myocardial edema in acute myocarditis. T1 mapping, which is very useful for evaluating fibrosis, and T2 mapping, which is very useful in detecting myocardial edema and inflammation. So when you look here at image A, this is just a diastolic frame from a complete cine acquisition in the left ventricular basal short axis view. Image B is the corresponding stir sequence image. Image C is T1 mapping, and image D is T2 mapping. So when you look at the stir image here, it showed no increased myocardial signal intensity. Some may argue that this area here, or this high signal intensity here adjacent to the anterior wall, is an increased myocardial signal intensity, but actually it only reflects a blood pool signal. And then T1 and T2 mapping in the same plane both showed normal myocardial values, excluding edema or inflammation, and thus excluding acute or active myocarditis. And then we've given her GAD, and this is here the late gadolinium enhancement sequence in the 2-chamber view, 4-chamber view, and short axis view, and it shows a transmural. So you see it includes the whole thickness, a transmural late gadolinium myocardial enhancement in the 2-chamber view, 4-chamber view, and short axis view, in keeping with transmural myocardial infarction in the left ventricular apical segments. And this year, cine images in the 2-chamber view, 3-chamber view, and 4-chamber view, showing severely impaired LV function and RV function, global hypokinesia, akinetic apical segment. The LV ejection fraction was calculated around 15%. The RV ejection fraction was around 12 to 15%. There was functional mitral regurgitation around 33%, calculated as the difference between the LV stroke volume and the aortic forward flow. So when you look at these findings, these CMR findings, and the distribution of the late gadolinium, it was in the distal LED territory. So these findings were consistent with embolic myocardial infarction involving the distal LED territory, most likely originating from the ventricular thrombi in the setting of a severely dilated cardiomyopathy. So how we managed this 3-year-old girl? When she presented to the hospital, she was quite unwell, so she was admitted in the pediatric intensive care. She had supportive therapy in the form of intravenous inotropes, diuretics, and fluid restriction. She had intravenous iron transfusion for her iron deficiency anemia. For the LV thrombi, she was started on heparin infusion with a target anti-10A level between zero point 0.3 and zero point 0.5, and follow-up echoes imaging showed resolution of the thrombi. And if you all notice that when we did the MRI, there was no any thrombi in the LV, because this MRI was done around 10 days after the initial presentation. And when she presented, we started her on heparin infusion, and in follow-up echo imaging around 1 week time, there was complete resolution of the thrombi. And that's why we couldn't see them in the MRI scenes. And the long-term plan for anticoagulation is for her to be transitioned to rivaroxaban, which is an oral anticoagulant. And her clinical status improved. She was transferred to the general ward and later discharged home in medications, diuretics, inoximune, which is a selective phosphodiesterase inhibitor, ACE inhibitor, and anticoagulant. And 1 month post-discharge follow-up, she was clinically well, asymptomatic. Her echo showed persistently severely dilated LV with severely impaired LV function, which is not different from her discharge echocardiography. So when you look at myocardial infarction in a young child, it presents a significant challenge, and identifying the underlying cause is particularly different because in the absence of coronary abnormalities, it often lacks the traditional coronary risk factors. It is frequently associated with non-specific symptoms, making the diagnosis through conventional methods very challenging. And when you look at this clinical picture, the initial diagnosis will suggest myocarditis. However, it's one of the conditions that commonly mimic myocardial infarction in the investigation and the way it presented. That's why MRI was very, very useful here in this case in differentiating between these two pathologies. Some may argue why we haven't done coronary angiography in this girl. So the decision not to proceed with coronary angiography was made following a multidisciplinary team discussion. First, her coronary arteries were clearly seen in multiple echo scans with normal origin and proximal course of the right and left coronary arteries. There was no doubt about the anatomy of the coronary arteries. And considering her very young age, 3-year-old, and the presence of an established infarct with severely impaired LV function, it was concluded that the risks associated with the invasive angiography outweighed its potential benefits, and that's why it was abandoned. So, how CMR helped in the diagnosis of this condition? First, the initial sequences that we have done, that I've discussed earlier, the STIR sequence, the T1 mapping, and the T2 mapping were very useful sequence in excluding myocardial edema and inflammation, and thus excluding active myocarditis. However, late gadolinium enhancement and sequence and the pattern of the gadolinium enhancement was very useful in differentiating the pathology. When you have a late gadolinium enhancement sequence of a myocarditis case, so these images here is I've just put them here to show how the late gadolinium enhancement looks like in a myocarditis case. So it will be subepicardial or mid-wall enhancement. You can see here in those 4-chamber view, it will be subepicardial or mid-wall enhancement, sparing the subendocardium. However, in myocardial infarction, like the images I've showed about in our 3-year-old girl, it will be transmural enhancement or subendocardial enhancement. That's why late gadolinium enhancement sequence is very, very crucial in differentiating between these two pathologies. So, in conclusion, myocardial injury in children present a significant diagnostic challenge. However, CMR is indispensable in distinguishing myocarditis from myocardial infarction. In this patient CMR accurately identified embolic myocardial infarction in the context of LV thrombi in a dilated cardiomyopathy heart and excluded active inflammation and thus excluded active myocarditis. And this guided the treatment with anticoagulation and heart failure therapy. Thank you. Any questions?